I'm Professor Louis de Mestier from Bourgeon University Hospital, and we're here to discuss the highlights from the practice-changing results from the ENETS 2026 conference. Alice, let's start with the PRRT. We had today very interesting subgroup results from the COMPETE trial.
Thomas Walter presented to us the subgroup analysis of pancreatic ENETS in COMPETE trial, show a huge benefit of PRRT for these patients over everolimus in terms of progression-free survival. And in all the subgroup, particularly with Ki-67 above 10%, but with functional or non-functional first or second line, which is very promising for these patients. And it leads us to conclude that PRRT seems to be a huge therapy in pan-NETs before targeted therapy.
And I think that today we also had some very nice results with the PRRT rechallenge in neuroendocrine tumor patients.
Exactly. We had the experience of 6 Australian centers for rechallenging PRRT in NETs, which is a huge question. Are we efficient? Is it safe to do so? So they explained to us that they took all primitives and rechallenging the PRRT. It shows us it seems to be efficient with incredible results. And it seems to be that overall survival is not impacted by the number of courses, 1, 2, and above 2. And what could be very important for decision making in the free interval between the first PRRT and the second one. And what a concern will be in the future is the hematotoxicity for this patient. So we have to be careful for these patients.
Yeah, absolutely. Thank you very much. Timo, at the other side of the neuroendocrine neoplasm spectrum are neuroendocrine carcinoma, which have much more aggressive behavior. And today we had the results of the Darion 7 trial, which were very interesting. Could you tell us more about that?
Yeah, so the Darion 7 trial is a first-line trial in neuroendocrine carcinoma, which I think is quite important to mention, where we currently have standard of care of carboplatin etoposide or cisplatin etoposide. In the Darion 7 trial, this was combined with obrixtamig, and obrixtamig is a DLL3 bispecific T-cell engager, which really engages the immune system to attack the cancer cells. The results were quite frankly impressive. We saw actually disease control rates of about 90% and a quite long duration of response, and even patients with durable response, so going on for many months, including complete responses after 1 year of treatment. This is something we have never seen before in neuroendocrine carcinomas. I think we will hear a lot more about this molecule in the future, and there might be a global phase 3 starting soon.
Yeah, very impressive. So this is for patients with advanced neuroendocrine carcinoma. What about patients with stage 1 to 3 NECs?
Yeah, so I think there was a very interesting presentation by Halfdan Sorbet, who is well known from the Nordic NEC 1 and 2 study. He presented data on stage 1 to 3 neuroendocrine carcinomas from EP-NEC sites, and this data was collected in a European collaboration. And really the focus of the presentation was on the role of surgery in NEC. This is very debated still, even in the guidelines it's debated. And there are some people that say there is no role for surgery in neuroendocrine carcinoma. However, I think the data shows otherwise, where we see actually quite nice survivals with patients that have been operated, and this is far better in stage 1 to 3 than the patients that have been treated with palliative chemotherapy. So it shows there is a role for surgery, and what is also striking, this survival was not correlated with T-stage nor with lymph node positivity upon resection, so there is something else at play. We don't really know yet what that would be, but we do see that there is a role for the location of the disease, with quite nice survivals in rectal and colon NEC, but quite poor survival in gastric NEC.
Yeah.
The good thing is that in those cohort patients, most of patients relapse within 3 years, and there is no relapse seen after 4.5 years. That's for me is also practice changing, but because it informs me how long do I have to follow my patients after resection with a neuroendocrine carcinoma.
Absolutely. Thank you very much. And finally, Alice, any highlights from new combination in NETs patients?
Yes, we had this morning an Italian study presented of the association of temozolomide and cabozantinib. It leads us to ask ourselves for the combination of those two molecules can be interesting, maybe with some larger study, with a larger number of patients. And it can be driven to MGMT status to help us to distinguish the good responder to this kind of association.
Okay, well, thank you very much, both of you, for sharing your thoughts on these highlights.